Hello and welcome back to my channel. If this is your first time here, I'm Nurse Alyssa, and today we're going to be discussing optimizing wound healing. Now, if you've ever been on my channel before, you know that I talk about this all the time. So I thought, hey, why not post a video that goes more in depth about optimizing wound healing? Because I actually have a website where you can book with me to optimize your wound healing if you have a wound that doesn't seem to want to heal. And these are some of the things that I go through when I am talking with you, okay? There's so much more involved. Wound care, it's kind of endless. You have to take all the knowledge and put it together. There's no one size fits all. But like I said, I will talk about optimizing wound healing today because these are some of the aspects that I do look at. So when I talk about optimizing wound healing, most often I'm talking about chronic wounds in general. Now, like moist wound healing, that's what we want for any wound. But when I'm talking about optimizing wound healing, most often it's with chronic wounds because these are wounds that have failed to heal in 90 days. Okay, so the cause of the chronic wound is so important to know because without the cause, how do we treat the wound, right? We might have an ulcer on the leg. Now, is it being caused by arterial or venous? We need to know what's causing this, looking at the signs and symptoms and kind of investigating. So as a wound care specialist, we're always investigating what caused that wound, what could be causing that wound, getting tests run to find out exactly what is causing that wound, because we have to know the cause to be able to heal it. Like I always say, we have to look at patients as a whole and not just as that specific little hole in the patient, because we got to look at them as a whole because we have to know the causing factors. Okay, so that's exactly why. And now we need to use evidence-based practice and treatment based off of the cause. Okay, and we're always looking and going through all the stages, the 4 stages of healing: hemostasis, inflammation, proliferation, remodel phase. Okay, we're always looking at the wounds to see what phase we're in. Most of the time with chronic wounds, we're stuck in that inflammatory phase and it just won't get to that healing phase, right? So this is more what I'm talking about when I'm talking about optimizing wound healing. So 10 key essentials of chronic wound management. So like I said, we need to be looking at the patient as a whole because the whole body affects that wound, okay? We need a physical examination. We need to examine their nutrition, their pain level, a wound assessment, compliance, self-care abilities, okay? If they're not able to change that dressing or do the plan of care that we have set out, we're not going to have healing. Do they have coverage? Are they paying it themselves? Okay, this all factors in when we're looking at chronic wound management, because if we're setting them up for failure to begin with, they're just going to go to something that maybe they can afford or maybe they can put on themselves. We need to be having these conversations so that social factor, okay? And if you haven't watched my video that I just put out, because it explains wound bed preparation, and if you're not aware, we have gone from time to timers, okay? And the social factor is one of the parts that has been added on. So I will link that video above if you have not seen that yet, and I will link it at the end of this video also. You should really watch that, okay? Because the wound bed preparation is critical in healing wounds, okay? So the 10 key components that are used for effective wound management. Wound etiology. So what's the cause? What is causing that wound? The wound assessment. Wound bed preparation. What is the depth? What is the exudate amount? Okay, that's going to give us our dressing wear time and the dressings we should be using. Okay, nutrition level. Are they getting enough protein, nutrients in their diet? Okay, do we need to supplement their diet? Do they have pain? You know, if somebody's in pain, I know a lot of people, because I hear this all the time. Alyssa, yes, I'm in pain, but I don't want to take these pain medications. I don't want to become addicted. Now, this is the one thing I hear all the time. Now, if we're taking pain medication appropriately, we will not become addicted, okay? It's when we're taking it without having pain is when it becomes an issue. If we're taking pain medication when you trigger, okay, I have pain, I should be taking something for it. Now, what's your level of pain? We don't need to take something that we would use for a level 10 pain when we only have a 5 level of pain, right? So you need to be looking at the pain level too, assessing the pain level. We don't need to knock them on their butt, okay? We need to just cover the pain, do enough to cover the pain. And if you have a lower amount of pain, but it's just that nagging, irritating pain, there are other things that we can be doing. Meditation, reflexology, like there's a ton of stuff that you can look up online to control pain without medication. Okay, so there's always those options, but if you do have a higher level of pain, we cannot heal when we're in that pain-like state. Our body cannot heal. Okay, so we need, pain is one of those factors that's often overlooked with wounds, but a wound cannot heal if you are in pain. Okay, now patient compliance, self-ability, lifestyle, this all comes in factor. Can they change that wound? Can they afford the wound dressings? Okay, is there something with their lifestyle? You know, I had a gentleman that he went to bowling every Tuesday night. Okay, now he was compliant constantly with his dressings, but on Tuesday nights he would take it off, throw on a bandage, and you know, it would put that wound, especially because he was up playing bowling, whatnot, it would put the wound back. And I kept trying to figure out, like, what is going on? What is going on here? You know, and we got talking. You need to talk to your patients. Why? Because exactly this. He had, it was a self-conscious. He was so self-conscious of the wound dressings that we were using because they were big, they were bulky for the amount of drainage that was coming out. And then he'd end up slapping on just a flat bandage and it'd become macerated and it would start, the outsides would start receding back and it would just be a mess by the time I would get back to it. And it's like, what has happened here? So he was doing this without my knowledge, and it comes to find out because he was self-conscious of the bandage. So then for that one singular day, yes, I used a bandage that was quite expensive, but for one night to not have that backward spiral of the wound, you know, he was willing. He was like, yeah, like I used a bandage that was very skin tone, that would cover the moisture for that specific amount of time, for the 2 hours he was gone, to be changed out afterwards. But we came up with a solution to the problem. Okay, so you need to be always talking with your patients, seeing if there's certain things that we need to look at. Okay, patient caregiver education, so just educating on the importance of compliance, and all of the things that we're setting in place. Why they need to know the why. Okay, if you didn't know why you were doing something, are you going to continue doing it? Especially with chronic wounds that are taking months and months and months to heal. If you don't know why we're doing what we're doing, and especially if we're using expensive products and they're seeing, oh, it's only closed like 3 millimeters in the last month. Well, 3 millimeters is quite a lot in a chronic wound, okay? Depending on size and whatnot, they need to know why. With chronic wounds, if we can get healing out of them, we are going to celebrate every millimeter, okay? We are going to celebrate that. So I want to talk about moist wound healing here for a minute, because to optimize wound healing, we want a just moist wound healing environment, okay? This would be about the moisture of our eyeball, okay? That's the type of moisture we want on our wound. Not too dry, not too wet. Too wet will cause maceration. Too dry will cause scabbing, necrosis, hardening of the tissue, scabs, whatever. However you want to call it, we do not want that, okay? We now know that a moist wound healing environment is what is going to heal that wound 3 to 5 times faster than letting it air out, because there is this huge misconception, and I hear it all the time. Well, I need to leave my wound to air out. No, you don't. No, you don't. No. We do not let our wounds air out to dry, okay? Now, I mean, there's some certain cases, and I'll talk to you about that in a minute here, that we don't want moist wound healing. But for the most part, moist wound healing is the best environment to reduce infections, lessen necrosis, inflammation in the inflammatory phase, and helps regenerate that new skin, okay? This is what we want. That's what we want out of our healing process, right? Lessen scabs or scars, okay? We want to reduce all that. We need a moist wound environment, okay? It also reduces pain. It lessens scarring. It is proven to be the best in wound healing. Now, however, not all wounds are appropriate for moist wound healing. If we have dry, stable, intact, necrotic type wounds caused by lack of blood flow, okay? If we do not have blood flow to the feet, if we have arterial disease, okay, and have necrotic ulcers, necrotic feet, whatever you might have that's necrotic caused by arterial disease, blood flow not getting to that area, we are going to keep that dry and intact, okay? Monitor it. Probably, personally, for me, povidone iodine, wiping that on it. It's a drying agent. Keep those wounds clean, dry. We don't want a moist wound environment. That is pretty much the only time I would say that I can think of off the top of my head where moist wound healing is not advised, okay? So there are advanced dressings. There's been so many advancements for moist wound healing, okay? Hydrofillers, honey gels, oils, petroleum gauze dressings, okay? These will help keep a moist wound environment just moist, okay? Devitalized tissue. Okay, let's talk about that for a minute. Slough, eschar, this harbors bacteria, okay? That's why it's no good. Moist wound healing with just a clean wound base is what we want, okay? So when we see slough, necrotic tissue, anything like that shouldn't be there, we need to be debriding it, okay? So there's so many different debridement methods that we can use. Use one of them. Use one of them, please, if you see that. Unless, once again, if it's caused by lack of blood flow to the area and it's dry, stable, we will leave that in place, okay? All right, so another part of optimizing wound healing is deciding what type of dressings are we using, okay? I always like to say we want a moist wound environment, okay? And then we're looking at, do we need debridement? Are we choosing to use our dressings for debridement? I personally, this is my least favorite type of debridement, is a wet to dry dressing and ripping it out of there to remove any non-viable tissue. Not my thing. I better say that. I mean, there's reasons to use it. It's not something that I like. It causes a lot of pain to my patients. I don't like to cause pain to my patients, so this is not something that you will catch me using. I like just a moist dressing. So in regards to packing wounds, we want to just pack them very loosely, fill up all that undermining tunneling very, very loosely. Me personally, I like it to be just a moist wound environment. Will create that healing atmosphere, not causing pain. It can stay in there for a day. You know, the wet to dry, it really needs to be changed every 4 to 6 hours. You know, so there's a whole lot involved with that. You would use that more in a hospital setting for the wet to dry, because obviously the patient's not going to do that for themselves. They will more than likely wet down that dressing to get it out of there with the least amount of pain. So really it's just kind of pointless then if you're getting that dressing wet after it has dried, because really you're using it to get all that junk out of there. I couldn't just stop there. I had to put disadvantages of wet to dry dressings because that's how much I dislike them. So like I said, most of the time the dressings get moistened, right? So then it's not so much of a painful removal, but this defeats the whole purpose of a non-selective debridement. Okay, it's labor intensive, 4 to 6 hours it needs to be changed. You're also cooling the temperature of the wound bed. So did you know it takes about 4 to 6 hours, sometimes even 8 hours, to get that wound back up to healing temperatures? So if we're doing this every 4 to 6 hours, cleaning out the wound, putting a new dressing in, where's the healing time? Okay, that's why I always love that sweet spot of a 2 to 3 day dressing, because it gets so much healing. Even when you're changing it every day, you're not getting as much healing time out of it. I love to optimize wound healing time, and every time we open up that wound base, clean it out, it cools down. It's going to take another up to 8 hours to get to healing temperatures. Okay, these dressings are super painful to remove. Okay, it also dries viable tissue. Okay, there could be dressing particles that are retained, and once again, bioburden can embed up to 60 layers of gauze. I just added that in there. So considerations for dressings capability. So will it absorb the amount of moisture that you need? Okay, is it a viscous material, like thick material? Is it going to absorb that? Okay, do the properties of the dressing interfere or deactivate the antimicrobial properties of your initial dressing? So you have the contact layer over your wound, and then your dressing goes over top of that. Not always the case. Not always the case, because like if you're using a foam dressing with a silver in it, you know, then that is your primary dressing. But when we're using a secondary cover dressing, we have to make sure that the properties don't interfere with each other. And I always like to say we're only using one antimicrobial, okay? So if you're putting a contact layer, your secondary layer should just be an absorbent layer, or whatever type of absorbent layer you need. We don't want two different antimicrobials or the top to even have an antimicrobial, because it's kind of pointless when you have a contact layer. Next, we have ointments, creams, thickness. Are we checking the correct dosage, ensuring efficiency? is this going to cause maceration? Okay, is the wound already kind of wet? And putting more ointments or creams on it, is it going to make it to that point of maceration where the wound starts going backwards and getting larger? We got to think about that. Wear time, okay, of medicated dressings. So are we changing them enough? How long is that dressing state that it's good for? Okay, some say every 48 hours needs to be changed, every 24 hours needs to be changed. Some are up to 7 days. Okay, we need to be looking at that. Cleanser capability. So are we using the proper cleanser with our dressings? Because did you know that there are certain dressings that you can't use sterile water for? Or sorry, sterile saline for. And we need to use sterile water. Okay, you need to be checking out your package inserts to find out what kind of solution can I use to clean the wound before putting this on. Is it going to deactivate the antimicrobial properties? Okay, we need to pack dead space like I just talked about. Just lightly fluff it in there. And cleaning the wound base, ensuring that we're getting rid of devitalized tissue, debridement methods. Okay, we need to be looking at all these things. So we want a good outcome for our patients. We want that wound to heal as quickly as possible. So when I say optimizing wound healing, we have to look at that patient as a whole, okay? Most important thing, we cannot heal somebody if we're not looking at them as a whole, okay? If they're having pressure, let's put pressure ulcer, for example, here. We may get that pressure ulcer to heal, but if we're not educating, looking at them as a whole, why was the pressure ulcer there to begin with? If we're not fixing the problem, not coming up with a solution to that problem, it's just going to reoccur, right? So even if we get that wound to heal, it'll just reoccur as soon as it's healed, and they're like, oh, okay, I can go back to just sitting all day, not really moving positions. It's just going to create a pressure sore there once again. Or what about with venous leg ulcers? Okay, if we're not educating, fixing the problem, okay, giving them a solution to the problem, okay, we need them in compression stockings. And then if we're not educating them enough, not saying, okay, you got to understand this is for life, because we can't, once that wound is healed, we can't just stop with the compression therapy. Why? Because it'll just create the problem again. That is how chronic wounds really are. We need to fix the problem, and it's a lifetime solution. Okay, but that's all I have for this video, guys. I hope you did find it very helpful for your practice. And once again, if you have a wound that you cannot heal and you want my help to optimize your wound healing experience, please check out in the description. I'll have a link there where you can actually book with me, and I can give you a specific plan specific to you. We will chat over a Zoom, and we will get those wounds healed. Okay, have a wonderful day, guys.